Mandatory reporting. Well, regardless of HIPAA, we are required by law, and HIPAA certainly authorizes this, to report certain things. We are required by law to report abuse situations, whether it's child abuse, elder abuse. Elder abuse, by the way, is a bit of a misnomer because it refers to all the statutes, recent statutes in California refer to all dependent abuse. It carries the same weight of law and reporting requirements and enforcement standards and so forth. And the key word there is suspect. You don't have to prove it. You just have to have reasonable cause to suspect that that the person was unintentionally harmed or intentionally harmed. Excuse me. And then we have to report domestic violence. Mandatory reporting, whether or not the victim wants it or not, wants it reported. And we have to report all violent injuries, whether it's a gunshot wound, stab wound, just a blow. Someone was hit, and if it wasn't mutual combat, we have to report it to the police. They come and interview. So this is why emergency rooms are substations for your local police department. We get to know our police and firefighters really well. So involuntary holds. You heard about 5150. And 5150, the Lanterman Petra Short, was basically created to balance patient and societal interests. Certainly we understand that patients have the right to autonomy and consent to treatment and to privacy and their confidentiality of medical information, right to freedom of movement and expression, and all of these rights have to be preserved first and foremost. But why 5150? Why do we temporarily intervene and create this paternalistic involuntary system? Well, because society thinks a danger to self has to be intervened, at least for a period of time, long enough to evaluate the cause. And quite frankly, we see that many suicidal situations are situations. They can be emotions of the moment. They can be situational issues that resolve. I mean, how often do you see it with adolescents that, oh, there's no problem. An hour or two later, there's no problem. There was just an extreme emotional outburst at a given time, and the pills were there, and I swallowed them. Well, what did you think would happen? I don't know. Did you think you might die? Yeah. Did you think they would kill you? Maybe. Well, do you feel the same way now? Well, no. Why are you keeping me? And I mean, this is the most common psychiatric chief complaint in our emergency department is kids who swallow pills. And so why do we have this paternalistic system? It's precisely to force them into evaluation. Because evaluation, basically, I think the legal justification is it's for psychiatric evaluation, but the practical justification is it's a cooling off period, and it works that way all the time, or almost all the time. So again, we talked about emergency doctrine. We've got to protect patients in society, one danger to self or others. So if a patient is a danger to others, and we talked about that being the more uncommon situation, but that's very real too. And then we have a unique consent issue under the Tarasoff case, where if a patient is a specific if we have information under this confidential doctor-patient relationship, and it doesn't just apply to psychiatrists, Dr. Sklar, it applies to all of us in these situations, all medical folks in these situations. If a patient discloses to us that they're going to kill somebody, then we have a duty to protect society in that instance and report that for the protection of that individual. And we have trying to think of the terminology when a patient is a danger to society. We also have to report, by the way, lapses of consciousness, patients who have seizure disorders. And there's another law that I have to break all the time, because people have lapses of consciousness, and you've seen the legislature acting on it right now. If you read the paper yesterday, they're reviewing the lapse of consciousness reporting requirement. Sure, if it's a patient who doesn't take their seizure medicine and goes out and like the man in Santa Monica that killed 10 people when he had a lapse of consciousness and it was a recurrent condition, the vicarious liability. The doctors in that case have a vicarious liability for not reporting that, and so that's why we have these mandatory reporting laws. But in general, some of them are, it's tough because it's tough to know where to draw the lines with respect to mandatory reporting. If you come in with a simple fainting spill, if let's say you got sick to your stomach or have the flu, technically I'm supposed to mandatory report, and the DMV is supposed to pull your driver's license until they've had a chance to interview you and know that it's not a recurrent condition. Well, that judgment ought to be made from the beginning, and that's why we're reviewing the law on mandatory reporting on that. Okay, so 5150 is a 72-hour detention period. Again, danger to self, others gravely disabled. It's placed by police officers, mental health professionals, and in Yolo County, the law gives each county the determination on who places 5150, and in Yolo County, it's all physicians can place and remove 5150s. So that's the county that I work in, but I almost never use it because I want that psychiatric evaluation by the mobile crisis folks to come in, and so rarely would I cancel if I told you about a case that I did the other day because it was patently obvious, but I still got the psychiatric evaluation on him. I still wanted, you know why? Because they have more time than I do. They can get into a more elaborate interview. And it's also a cooling off period because it always takes them about 2 or 3 hours to come and see the patient at a minimum. And then on patients that need to be placed, it'll take hours after that. And it's a period of time when that allows for me to get a double check on my own decision making. But those are consultations, I might add. They're consultations to the physician. Ultimately, under EMTALA, it's up to the physician to decide if there's an emergency. And so the 5150 issue, even though it's a separate body of laws, it's the psych evaluation folks are actually consulting for the emergency physician to make a decision whether or not to discharge that patient. Now, in most counties, I doubt if San Francisco County, the doc has the 5150 authority, so they have to work in concert with the psych, with the PET team to make that decision, both from an EMTALA point of view and from the state law point of view. Then you have your 14 and 30-day treatments and capacity hearings and conservatorship hearings and all those additional things under LPS. By the way, and then unique thing is that in 1979 we passed a emergency department 8-hour hold. which allows us to have an 8-hour window for holding folks and basically what it was for was to do the medical evaluation, to be able to perform medical clearance on complex issues like drug and alcohol detox. Often takes 8 hours to know whether or not a patient's going to go into DTs. It often takes 8 hours for a person to sober up to get to a point where we can even talk to them and make an informed judgment. We got this 8 hour, and it's purely arbitrary. Why 8 hours? Because 8 hours covers about 99% of the times when we need this authority to hold people without a 5150, simply for the purpose of performing these medical evaluations and medical clearances to the point where we can get to deciding whether or not they need a 5150. So that's what the 8-hour clearance is all, the 8-hour hold is all about. The second stage of it was we wanted to get to the point where there's a lot of folks who you can't clear in 8 hours, and you have to admit them to the hospital, and it may take, maybe it's diabetic ketoacidosis or something. It may take a couple of days to get them stable enough to the point where they can even evaluate them psychiatrically, and there's no provision for that. And the hospitals there's no liability protection or immunity protection for hospitals in that instance. And they're constantly having to hold people against their will for that purpose, to medically stabilize them, to get them to a point where they can, and basically that's kidnapping. It's false imprisonment. They're basically, in many instances, holding people against their will. As it turns out, maybe that will becomes more apparent over time when they're finally well enough to be able to protest. And so they're caught between the rock and the hard place on trying to do what's right for the patient. How do they make those, what's the final determinant on how they make those judgments? Well, it comes right down to, courts and lawyers and malpractice liability. Am I more likely to get sued for releasing this patient too early or too late? And most of the time, it's for releasing a patient too early to come to a bad outcome because they fail to treat. So they tend to err on the side, I don't know if you could even call it an error, but you're going to, this sort of holding patients against their will is a real problem, yes, but undertreating is a bigger problem, and certainly a bigger problem from a malpractice point of view. So then about observation, seclusion, and restraints. Again, we put folks close to the nurse's station, or some EDs have specialized detention obs areas. We make sure that they have gowns to wear. And the most important article of clothing to remove is the shoes, because if you don't remove shoes, they can run just as fast in a gown as they can in their street clothes. And I recall recently we had a kid who ran across the freeway and almost committed death by suicide. And he was our patient. He had a gown on, and he should have been restrained. Almost, I should say, death by cop. He tried to attack an armed police officer in order to carry out his death wish. And pity that poor police officer or that family or that patient if that had happened. And that's why we have to restrain people and take away their shoes. And there's all scales of restraint. It can be simply telling a person that they have to stay, that they're under detention. It can be one softie, just to remind them that they can't get up and wander all over the hospital. But people are very clever. They get out of all forms of restraint, whether it's full leathers, four-quadrant leathers, et cetera, et cetera. And in general, we're told by the regulators, and in terms of liability experience, that we don't use enough chemical restraint. That, in fact, physical restraints are dangerous, People can hang themselves getting twisted up in these things, especially if they're not observed often enough. And by the way, we have to refresh our restraint orders every 4 hours. And the nurses have to check on patients in restraint in physical restraints every 15 minutes. Because this surfaced as a big issue with the Joint Commission and with the patient safety experience over the last few years. And
excuse me, I was out for a second. You might have said this. Are folks in this category already on 5150s, or
they don't
in order
have
to fit on that page, does somebody have to already be on a 5150?
No, we have an 8-hour hold in the ER.
Oh, these are people on the. Oh, you mentioned the 8-hour holds.
Yeah.
As I was going out.
And it may be that until we can get them medically stabilized enough to evaluate for a 5150, that they're restrained the whole time.
And you do all this in an 8-bed emergency room.
Sure.
How many beds do you have set up for this of your
Well,
8?
we don't have any. We're not like a big ER that has a specialized detention area, but I've had 3 and 4 psychiatric holds in my department.
So these are
at the
just
same time.
regular medical beds that you convert to psychiatric beds as needed?
I got 4 beds close to the nurse's station, and any one of those can work for this.
Yeah, along the same lines, I just want to make sure people understand that the rules for seclusion and restraints, whatever kind of hold you're on, are really specific, that the restraint has to be the least restrictive alternative to do what you need to do. You have to try simply telling the person that they're on an 8-hour hold or a 72-hour hold and hoping that won't run away. I'm not sure even taking someone's shoes away if they want to wear shoes is appropriate unless you have a reason to think they're going to leave. Now, on this 8-hour hold, I realize you're talking about people who need detox. It's a little bit different. But for any kind of hold, you can't use a physical or a chemical restraint unless you really need to, and then only to the extent to which you need to do it.
Yeah. And you remember the death by cop case that I told you about? He had, over the course of a 4-hour period in the ER, he had, we went back, and when we reviewed that case, first of all, he was coaxed by the nurses to stay several times. He got up and started wandering. He went to 1 softie, then to 2 softies, then to leathers, but his shoes were under the bed. And he found his shoes, and he dashed. And that's with that final event to where we finally use chemical restraint, and we should have used it a lot earlier. And so what I would say is that yes, you have to use the least possible, but it requires a whole lot of observation to be able to make those judgments.
You're right, and I guess my point is that the law requires that observation and those judgments to be made on each individual case, and that it's not legal or appropriate to assume from past experience with that person or other people that you're going to need a certain kind of restraint. And I mean, I know it's easy to think that way. I'm not suggesting that you do. I'm just making the point that they do have to be individual judgments.
Right. And by the way, the vast majority of 5150 evals in our ER are not restrained at all, except verbally. So yeah, point well made. So then consultation and placement. And I talked about mobile crisis. We use daytime mental health in Yolo County, and then mobile crisis after hours. There's always a problem at 4 o'clock in the afternoon and 7 o'clock in the morning. Those are the witching hours. It takes at least 2 hours to transition those. I don't know why there's a 2-hour break. Theoretically, one goes off, the other one comes on. You'd think that they wouldn't have any, but there's always a handoff issue here. And then they're usually tied up seeing the 3 or 4 cases at the other hospital across the county, and so it may take 4 or 5 hours to get them in. They're great people. I couldn't do what they do. They do a wonderful job. But then they get into the phone tag thing. After they've gone through an hour or 2 evaluation with this individual, they're calling around trying to make placement, trying to decide what county the patient came from, where their usual services are, sometimes it comes down to buying the patient a Greyhound ticket voluntarily so they can get back to their to the place where they usually get services. There are just so many nuances in this, and the services have been massively overcrowded. So we get into a gridlock scenario where we're holding these patients for more than 24 hours at a time until placement can finally be effected. And I told you about the blood alcohol thing, that for some reason they got a medical legal burr in their saddle about making sure that blood alcohol is under 100 milligrams per deciliter, 0.10. And you try and explain to them that, well, with my alcohol-dependent patients, they're already in withdrawal by the time they get down to 1.0, so they're no longer going to be able to be evaluated if you don't evaluate them now when they're at 0.20. But that doesn't compute because it's a different world. They've got, I've got my orders. I only do less than 1.0, or do less than 0.10, rather 100 milligrams per deciliter. I said that wrong, but you know what I'm talking about. It used to be the California legal driving limit, 1.0. Now it's down to 0.08, but they use 1.0. And then a lot of times they throw monkey wrenches in. They want a tox screen for everything known to man. I think I finally had it one time when they asked me for a patient who had taken a tetracycline overdose, and they wanted a tetracycline level. And there's no such thing as a tetracycline toxicity. So occasionally we have to powwow with the various services and explain that we do toxicology also. We have to make those judgments. But it's tough because I know of patients who've died of taking huge overdoses that turned into rock-hard Bezors in their stomach, and you couldn't pick up on it through the medical clearance. Medical clearance is very tricky, especially when people are out to fool you. They can do it a lot of times. So, and then transfer has some particulars under EMTALA. Patient is stable if they're no longer a threat to self or others, and stable for transfer. And the way you make them no longer a threat to self or others is if they're a threat to self in the first place, you restrain them. And I told you that physical restraints are dangerous, well, especially in an ambulance. If they can get out of them and jump out of the ambulance, that's generally not good to have your name be in the newspaper for that one. So we use a lot of chemical restraints for transfer. And then that can sometimes confound the psychiatric evaluation and make it tough to evaluate those patients within the 72-hour detention period when they go to the psych evaluation facility. And then a lot of psychiatrists, and this is no offense to Dr. Sklar here, but have never heard of EMTALA. So I've had to explain to them that they're required, if they're a psychiatric hospital, they have a higher level of capability. If they have the capacity, they're required to take my patient. So I remember one week when I had two women, very similar stories. Post-amphetamine psychosis. They were not acutely intoxicated on amphetamine, but they were psychotic from using meth. And one of them was throwing ashtrays at cars. I forget what the other one was doing. But in both of these instances, the psychiatrist said, well, that's a substance abuse problem. I don't do that. And the answer was, is your hospital in the United States? Yes. Well, if your hospital's in the United States and it participates in Medicare, then I'm required by law to report you and every other psychiatrist that refuses transfer of this patient. Do you want me to report you and be subject to a $50,000 fine? Go ahead and send the patient. So that, I think psychiatry has, and the whole mental health community has started to at least know what EMTALA is, and that it does preempt many of our state laws and requirements. So, but then we got gridlock and constructive denial of service when everything's crowded and hospital. If the hospital doesn't have capacity, they can refuse the transfer. So in essence, this promise of EMTALA becomes an empty promise. So we got to balance the duty to protect patients and society, and balance that not against, but with the patient's right of free movement and expression and autonomy and being able to decide what to do with their own bodies and minds. And I must say it's one of the tougher areas that we have to practice in, and it requires a lot of judgment, and it's a challenge in an overcrowded environment. Thank you.
I was just trying to get my question in. Being 5150, I'm glad to. I'm a consumer. I'm really educating myself of all these terms. I'm EMTALA as well. I guess maybe I'm thinking most police agencies have their own psych wards. In Santa Clara County, they do have their own psychiatric build. I think it's building, floor number 8. I personally was there. So I'm just, and there is no proper licensed staff. And I think they've been recently under the microscope for just for the recent lawsuits they've had. So I'm wondering, I know Agnew's facility closed down, so they're shifting many of the people into the county jail rather than to psych. So get to the question. All right, 5 minutes. Okay, 2 minutes. So Mike, I know you said you work, there's 8 beds in your facility, but in a county you have so many people. How can you determine, who should stay and who should go? But so I'll just sum it up and finish it up.
Dr. Johnson, do you have any response or comment on this gentleman's comment?
Well, I think that when we get into these we've known that we've warehoused mentally ill in jails now for decades, and a lot of that was a shift in health policy that occurred, back with the Great Society and with Lyndon Johnson, and when we decided that everyone was going to get access to insurance and the promise of private medical care, and that a lot of the funding by opening up rights of access, it created a promise for rights of access and equal opportunity for care in the mainstream of healthcare. That was the theory, and so we had many mental health institutions that were previously financed by other means closing down, and we had many, and then there was a presumption that pharmaceuticals would be the answer, and that people could be tranquilized and kept off the streets and out of jail. And you see what happened with that. So the ER is now the kind of the new answer for all of this, and the new warehousing is in holding people for extended periods of time and trying to get them transferred in gridlocked situations of hurry up and wait. And 72 hours may seem like a long time, but it's nothing compared to how long. I mean, it may take 72 hours just to talk to the psychiatrist or the LCSW who's going to make the decision at the end of that 72 hours. Things are stacking up like crazy, and that's the new warehousing.
Yeah. Of course, the old warehousing still exists too. We're still warehousing people in jails and prisons. And back to my comment about the ADA does require that mental health services be provided in jails and prisons. Not that necessarily happens all the time, but it is a legal requirement.
Yeah, I'd like to make a comment and ask a question. I think I really liked your presentation, and I really just like to say that Marcus Welby is not dead. He's living and working in Davis in the emergency room. You really did sound like the modern day equivalent of Marcus Welby. I really didn't understand until 10 minutes ago that EMTALA applies to transfers as well as basic emergency medical care. I'm interested in the answer to that. Maybe other people aren't, but could maybe 1 minute?
We
and then-
have about 10,
Yeah.
10 more minutes.
Oh, we do, okay.
We
So could you
close.
talk a little bit more specifically about the obligation of psychiatric facilities to accept patients? In our county, we're often told there are no beds. There are no beds at the county hospital, quote unquote. We can't admit your patient. There are no beds. How do you understand that? And how that fits under EMTALA?
Well, if you just look at it, EMTALA again applies to all hospitals that participate in the Medicare
Right, which
program.
is all hospitals.
And so it's not necessarily going to apply to PUF units and non-hospital facilities that counties have set up for psychiatric evaluation. Is not going to necessarily apply to a private psychiatric
Right.
specialty hospital.
County psychiatric hospital.
And-
Say I'm talking
And
specifically about.
Again, if it's participating in Medicare program, then there isn't an obligation to accept transfer for higher level of care to stabilize a patient with a psychiatric emergency. If you have the capacity and the higher level capability, capacity and capability are the two operant terms. Capacity means beds for what you would ordinarily handle. If you haven't been able to hire nurses and staff, the South Wing for the last 6 months, then just because you've got a room and a bed there doesn't mean capacity. But it's what your hospital ordinarily handles, even in an overflow situation. And so generally speaking, that would be a bed and the appropriate staffing for that bed.
Right.
Capability would be, my hospital has 2 psychiatrists on staff, and they only make rounds in rare situations on inpatients. We don't have inpatient psych capability.
Right. Mm-hmm.
So your county psych facility clearly has a higher level of care capability. So I'm the transferring doc. I'm the ER physician on the phone. I got 10 beds or 8 beds and 15 people all trying to squeeze in it. And I've got this patient here who we finally got to the point where we can make a disposition and attempt to transfer. And if you tell me I don't want that patient, that I would say you're violating the law. If you tell me I don't have any beds, then I've got to shop around somewhere else. If you tell me, well, you could handle them as well as I can, I'd say you're violating the law. If you tell me if you tell me that your qualification isn't any higher than mine, then I've got to shop.
Well, what happens when you shop until you drop and you haven't found anything?
Well, this applies not just to psychiatric
Right.
conditions,
Or any
but
other, right.
but to all of them. I mean, we get in profound cases of gridlock and not being able to transfer patients, and we do that. The answer is you just do the best you can in every given situation, and you keep trying, and you use chain of command. Chain of command is I call the chief of staff, I call my hospital administrator, they call their hospital system chain of command. And, the government loves to regulate, but they do everything in hindsight. We use chain of command in a real-time situation to try and muster whatever help we can get. And the terrible problem we're facing now is the on-call crisis in California and all over the country, where especially backup, not just for psychiatry, but for all specialties, is basically disintegrated because the government mandates EMTALA on hospitals, but hospitals can't mandate it on their medical staffs. And the law doesn't specifically address the medical staff issue. So this has been a terrible conundrum. This is the weak link in the chain of survival, and the answer is you do the best you can.
Thank you. A good answer. I just want to add this, and it's just food for thought in preparation for the seminar. I read a few studies with regard to different treatment for people with mental illness and without mental illness. One of the, I guess, better known ones was at the VA hospital. It was MI heart attack patients, and in terms of the angioplasties, there was a statistical difference between the medically indicated treatment in that people with mental illness got less. And what I want to throw out is the possible explanations for this, and some of them we've talked about. One, of course, is consent or informed consent. Another one is integration of provision of services, which means that generally people with mental illness have a better chance of getting the same level and degree of care if they get their mental health services along with other services at the same place. Now, whether that's because of availability of record or interchange of information between the cardiologist and the psychiatrist working in the same place, and the VA is an example of that. Other possible reasons are physician bias against people with mental illness, and also other provider bias. It could be institutional bias by hospitals and so forth. Now, the number of patients with mental health issues at any facility would be a causative or could be a causative factor, as is lack of trust and also failure to follow prescribed treatment. Now, this is on the part of the individual, the patient with the psychiatric impairment. Other factors that have followed some of these studies that have come to light include inaccurate assessments, and people with mental illness, at least in some studies, have fewer visits for medical treatment than people without. And there's also, I'm just going to throw this in because there are all kinds of factors involved, and it's not clear which is an age factor, that people who are under 50 tend to visit, seek medical care. People who are over 50 would seek it less, just like people with psychiatric impairments may seek it less. Now, I'm just throwing this out as food for thought. This is not, the answer and the explanation for why some studies are showing, based on empirical evidence, that there is disparate treatment. This one, MI, myocardial infraction, of course, is a heart attack, and this one had to do with angioplasties, this particular study. But it's just interesting to look at the different factors. Some of them are from commentaries, not from the actual studies, of all the different factors. And the bias one, and I'm assume it's just a lack of education, begs another question, and whether it applies to emergency room assessments, or someone mentioned that with respect to police would lead to education for service providers. And then the question is, should it be on the job? Should it be or before then in the educational system? Medical schools, would be an appropriate place. But I don't think there's clear answers to all these factors.
I'm not at all
throwing
qualified to comment on it, but I will.
Okay.
Hasn't stopped us yet, has it?
certainly there might be a bias that generates over missed appointments and things like that, and over compliance issues, and recognize that, for example, smoking cessation would be a major determinant of angioplasty failure rate.
Mhm.
And so is that a legitimate reason to yay or nay on making a decision? No, certainly it is not, and that's not you, but it is in heart transplants on very expensive things and very high intensity things, and recognize also that now you got the government getting into pay for performance, and your angioplasty failure, so there may be
So the age is a big factor, too.
built-in institutional bias being created over the doctor's individual angioplasty failure rate performance. Gee, would there, can you start to see certain incentives for why that bias might occur? Well, of course you can, and so. I think you have to look at a lot more factors. Things like.
Oh, I thought I had a long list.
things like smoking cessation and that sort of thing, rather than turning around and because doctors are kind of fun targets. When was the last time you saw an article in the newspaper that said, well, we did this study and we found out that the doctors were doing a wonderful job? It doesn't happen. But that doesn't bother me. It's the issue that it's usually multifactorial. It's usually not that simple.
I think there was some combination of all these symptoms, possible causes for the results of the studies done. I don't have the answer. Certainly, the failure to follow prescribed treatment would include failure to quit smoking. Whether it's partly patient and partly the doctor, it could very well be a combination. At any rate, on behalf of the People with Disabilities Foundation, I want to thank Pamela Cohn from Protection Advocacy, Dr. Loren Johnson from Davis, California, and our point man on psychiatry, Dr. Sklar, practicing psychiatrist. Some panel members may be available for questions up here after the seminar, which is now concluded. Thank you very much.